So today I am going to talk about mobility and geriatrics. And with that, how we can engage the elderly person into knowing the importance of mobility in their life. So we will have the objectives here. I'll let you kind of read through it. We're going to kind of look at ways to identify and screen for mobility, and then kind of get into how to we could apply some intervention and the benefits of doing this, the promotion and maintaining of mobility in the older individual. So this is just a refresher of the 4 M's. So in other talks, you've heard about the 4 M's framework: what matters, medication, mentation, and mobility. And we'll be focusing on mobility, but hopefully through the webinar, you'll see that all 4 of these are interrelated. So when we're dealing with one, we're actually dealing with all of those. So mobility can be impacted by the other 3 and vice versa. So recently there have been an additive to the 4 M's. The 5th M, multi-complexity, has been added. And so these are all evidence-based entities that go together with geriatrics. So just to kind of look at that, they all kind of wrap around what matters with the older adult and the caregiver. So we're going to focus on mobility. This is making sure that the older adult is able to move where they want to move every day, and that they're able to move safely. So screening for mobility or mobility limitations and documenting them is very important as healthcare providers. And again, to make sure that the mobility is safe, and we'll kind of get into that. That ties very closely to what matters. If I were to ask my patients when I worked in the clinic, what are your goals? And the goals were always, I want to be able to walk, I want to be able to drive. They wanted to be able to get out and explore what matters to them in the community. And so when we limit mobility or restrict activity, it really puts a damper on what matters to them, what they can do. So mobility is a very important factor in that quality of life for a geriatric client. So what is mobility? Why is it important? So mobility is the ability to get where you want to go when you want to get there. So the CDC had that in their definition, which I think is really appropriate description of it. And a mobility to the healthcare professional is an indicator of how well that older person is aging. So as mobility declines, we see that there's also declines socially, psychologically, and physical consequences that occur. So in health and nutrition, independence. And loss of mobility makes a difference if the person can continue to live on their own independently. So usually when the person's mobility declines, that's when the family or the individual is looking for more of an assisted living. And Brown and Flood found that it's closely linked to mobility problems are closely linked to falls, chronic illness, decreased bone density, and mortality. So it's very important for us to try to keep the aging adult as mobile as possible, because we find that there is problems that occur when we have decreased mobility. So most common risk factors for mobility deficits: older age, we get weaker, I should say potential to get weaker, have a potential to lose mobility through flexibility of our joints. We might have some balance issues. The other big risk factor is little physical activity. So if people do less, we're also going to impact the mobility. Linked also is increased weight gain. So people that are more obese tend to not move as much. Strength and balance impairments. Somebody is feeling weak or low endurance, or they feel unbalanced, that can have the impact on mobility. And of course, that chronic disease, like we talked about, the fifth M, having medical complexity that's going to occur, multiple things such as diabetes and arthritis. There's other less common red flags, but we should be aware of them. Depression, memory deficits, people with dementia or Alzheimer's, their mobility might be impacted more by their cognitive impairment. Being female has a greater risk. Recent hospitalization, there's been evidence that show that people have recently gone in the hospital usually have a decline in mobility, and drinking alcohol, feeling helplessness, going into the depression. So some of these risk factors are not modifiable. You and I are going to age no matter what we do, we get older. But a lot of them are modifiable in little physical activity. Can we have an impact of changing that? The obesity, can we lose weight? Yes. If a person has strength or balance impairments, can these be improved? Yes, with our intervention. Can we control diabetes? With a person being more active, can we limit the effects of arthritis? Not totally, but we could have some influence in that area. So it's very important when we talk about mobility, is what can we change and what might be things that we have to adapt to. So just major mobility concerns. Big one out there is fall risk. So falls are a leading cause of injury and death in adults over 65. And scary, these have been increasing by up to 31%, Byrne has indicated. So there's lots of falls. There's a fall death every 20 minutes that occurs. And that's something that, again, I think some of that can be prevented. What are the causes? And we're going to talk about that today. Has impact on financial cost. And it also can, just like we have the pain cycle that occurs, you got pain, you don't move, you get more pain, more in mobility. You can get this fear of falling cycle, like the pain cycle that occurs, which you get an increased decrease in mobility. So we want to be able to assess patients' mobility and give them some intervention that can impact. So there's evidence-based information out there. There's a systematic review by Gillespie that showed that intervention was helpful with use of exercises, reducing medication, and improving home safety. Were all beneficial to helping. So this is showing that fear of falling cycle that can occur. The fear of falling can reduce mobility and the person's activity. You get deconditioning, where you get weakness and low endurance. This causes increased risk of falls, leading to falls, and then it just repeats. So one of the highest risk factors of falling is having a previous fall. So it's very important that we can intervene in this to try to prevent that cycle from occurring, because the person's going to just get weaker, get less mobile, and create further problems. So there's a lot of information out there on the CDC website. If you look at the STEADY program, STEADY is Stopping Elderly Accidents, Deaths, and Injuries. It has a great resource for all clinical personnel. Does a very nice job. You're able to download their information and use it as you go through. So I'm going to refer to some of the CDC STEADY program that we can use with our screening and our intervention. So one of the things it talks about is to look at how can we improve mobility is by looking at that fall prevention. So looking at screening, then assessing, identifying what is modifiable risk factors that we talked about a little bit earlier, and what are effective interventions that we can do with that. So I kind of built the case that we're going to talk about today into the PowerPoint. So I'll introduce you to Mrs. Brown. Mrs. Brown is a 78-year-old female who lives in her home independently. She's coming to your clinic for an annual senior wellness visit. So when you come in for annual senior wellness fitness, you do have some general type of examination you're going to do, but what do you want to know from Mrs. Brown subjectively when she comes in? What are some things you might want to ask her?
Mary D, we do have a question in the chat. I don't mean to cut anybody off. So it says that female was listed as a link to more frequent falls. Can you please expand on that a little bit?
In literature, well, and I think as we get older, we get a increase female greater in the older population. But there has been a link that more falls in females than males. Why this could be linked to more problems with osteoporosis. It could also be linked with just the greater female population in the elderly age group.
Okay, thank you. And we do have a few comments to the question you had posed about this case study. Somebody had said that meds might be a possibility to look into.
Exactly. Excellent.
Okay. Another person also said medications, and then what other, maybe asking what other concerns that person might have.
Exactly. So let's see what we found out from Mrs. Brown. When we took Mrs. Brown's medical history, we noticed that she was wearing glasses, and we noted that they had bifocals. She had, in her medical history, she had orthostatic hypotension that has been a problem in the past, hypothyroidism. She reports to you that she has some urinary incontinence. She usually gets up twice a night to go to the bathroom. She has a history of some depression and anxiety. She's had some medication to help her with that. She's had some tachycardia that actually led to a mild stroke 3 years ago, and she is taking medication to control that. And she does indicate to you that she has had a recent fall. So looking at Mrs. Brown's medical history, what are your concerns regarding this history and in relations to her recent fall? Are there things that you want to know more about now that you have a little bit more of her medical history?
So I'm not sure if you're seeing the chat, Meredy, or not. Would you like me to read that to you? Or I can. I certainly can.
I could Does she have rugs or what happens with her fall? That's very good. Is the fall intrinsic? Did she just kind of, I don't know how I fell, I ended up on the floor, or did she trip on a rug? Did she fall inside or outside? Does she have balance issues? Those are all good. Let's see what else we have here. Does she use what kind of equipment does she use to walk? I think we talked about the medications important. Just go down here. Hearing, how is their functioning after stroke? And we'll say that she's pretty high functioning. More information on vision. We could do a visual screen if we needed. And yeah, is she using an assisted device? We'll say at this time she's not. But when you look at the medical history, bifocals can be a factor that cause problems with falls. The person looking through the bifocal, stepping down the step, especially if it's rather new glasses that she's having, they can be a factor in falling. Orthostatic hypotension, would that have an impact on causing a falling? So when she goes from lying down to sitting to standing and she gets a little lightheaded, we might want to ask a few more questions with this. Hypothyroidism, if she's being treated, may not have too much of a problem. What about if she told you she fell on the way to the bathroom? So does she have urinary urgency when she gets up at night and she rushes? Could that be something we could deal with regarding her mobility? Maybe she would be better off having a night light. Maybe she could be better off making sure maybe she limits her liquids before she goes to sleep, or maybe she uses an assisted device. The mention of medications, we're going to talk about with medications possibly create balance problems. The mild stroke, could that relate to it? So when we look at mobility, we have to look at all those other factors that we talked about with those 4 M's also. So what might be some questions about Mrs. Brown's mobility you might ask? So we talked about, does she use an assist device? What other things about the mobility might you ask? Is her home safe, free from trip hazards? We're going to get into that. The CDC has a little checklist you can use looking at the home. Okay, so that would be good. Does she walk for exercise? Excellent. So is she getting out and moving? Or since her fall, has she been sitting in a recliner and not wanting to worry about falling again? Did she restrict her activity? So you might want to get a little bit more objective data. So Haley talks about, does she have any adaptive equipment? So does she have grab bars that might be in her bathroom? Those are all really good questions. So let's see what we might find out here. There are some quick screens we can do for mobility. So we could certainly ask the person some questions, but in primary care, they've come up with some quick screens you can do for mobility. So the first question is, for health or physical reasons, do you have difficulty climbing 10 steps or walking a quarter mile? Mrs. Brown answered no. She's able to walk a quarter mile and she can climb up her basement steps. Question number 2 of the quick screen is, because of underlying health or physical reasons, have you modified the way you climb 10 steps or you walk a quarter of a mile? She answered no. If she would to have answered yes, we would do a referral to a healthcare provider and get further assessment and intervene to address her loss of mobility. So this might be going to a PT, looking at strength, balance, mobility, looking at those assisted devices, or maybe a referral to OT that's going to look at her living environment or how she's able to do her activities of daily living. It may be looking at social services, looking at ways that she could get transportation if she had trouble doing those. So depending if the person answers yes or no, those are two quick questions to just assess if there's mobility restrictions. Okay. So if we go further, what would be appropriate questions you might ask to screen for Mrs. Brown for fall risk? And question number 2, how might you identify a self-assessment screening tool you might incorporate into her wellness visit to screen for fall risk? So what might be a simple question you would ask her about fall risk? Have you fallen before? Excellent. So that's a big risk factor, is people have fallen before. Does her answers match her skills or task? Yeah. Medications using, yes, excellent. So anybody have ideas of a screening tool that you might use to give you some objective data regarding her fall risk?
Get up and go.
If not, I can get up and go. Good one. Yeah, so there's the get up and go, which is the GUG, or the timed up and go. The Berg balance scale, yes, those would be very good. The Berg might be a little beyond screening because it takes a little bit longer, but it's still a good test. The timed get up and go is very simple, easy test that takes just a few minutes. Those are both excellent. So let's go ahead. Gait speed, yeah. Gait speed would be another one that we're going to talk about. So when we're screening for fall risk, and she indicated that she can go a quarter of a mile and she can go 10 steps, we might want to ask 3 additional questions. If we get a yes response to any of these 3, we would want to assess further. And so we already identified some specific fall risk factors: postural hypotension, medications, comorbidities we've talked about. But the 3 additional questions would be, have you fallen in the past year? And she has. She recently has fallen. If so, how often? We'll say that she has fallen once in the last year. After her stroke, she might have had a few. We could go into that in more detail, but we'll be more concerned about this last year. How did it happen? So why do you think it's important to know how it happened? If she fell and she didn't know how she got on the ground, if she had an episode that was more medically related, we might go a different route. If she fell because she just started a new medicine, we might evaluate what medicine she's on more specifically. If she tripped over the dog leash walking her dog, more of an extrinsic factor, we might address ways of how more safely to do that. The second question is, do you feel unsteady when standing or walking? She has a history of orthostatic hypotension. So could that possibly be playing into when she first gets up that causes her unsteady? If her fall occurred when she got up, I felt really dizzy and I fell. And then the third question, are you worried about falling? And so we talk about the cycle of fall, fear of falling, decreased mobility, decreased conditioning, falls rate increases, you get that confidence that decreases. That can be a concern also. So the CDC in their study program has a checklist called Stay Independent Questionnaire. And this would be additional to the 3 questions. If somebody said yes, you could get more specifics, and I'll show you that up next. But if they score 4 or greater responses, that would indicate a greater risk of falling. If not at risk, but she scored a 1, 2, or 3, you still would want to intervene by educating on fall prevention. You might refer to a community exercise program at the senior center or at the local gym. There's fall prevention programs like the Stepping On program that occurs. But let's say that she had scored greater than 4. So we'll look at this checklist right here. And the CDC fall risk checklist indicates, have you fallen in the last 2 years? If you answer yes to that, you actually score 2 points. Have I used a cane or walker? Sometimes I feel unsteady. I steady myself holding furniture, and you go through these questions. The other one that Mrs. Brown lost a point or gained a point on is I have to rush to the toilet. So she got a 1 for answering yes there. I take medication that sometimes that makes me feel lightheaded or more tired. She got a point there. And I take medicine to help me sleep or improve my mood. So she was taking that due to her depression. So we added up the score. She got 2 here, 3, 4. She actually scored 5. And that would put her at a higher risk of falling. So a very simple checklist you could give to the person to do. It kind of talks about why this matters, but it kind of checks off those things we talked about earlier. So when we asked Mrs. Brown, she reported she fell outside when she was walking last week. She didn't physically get hurt, but her pride was bruised. She was kind of embarrassed. She didn't want her neighbors to see her fall on the sidewalk. She said she wasn't paying attention where she was stepping, and she tripped on a sidewalk crack. Her side that she had a little bit of weakness from the stroke. She kind of caught that toe. She usually walks about a half mile each day, and she feels fairly steady when she's walking. She tries to get some exercise. She usually tries to watch out for those cracks in the sidewalk, but she was a little distracted that day. She's not afraid of falling, but when she's out on firm surfaces like a sidewalk, she gets a little less comfortable when walking in uneven surfaces. And she was wearing her sandals when she was walking at this time when she fell. So she reports that her only real exercise is going for her daily walk. Okay. So when we look at talking about how confident a person is with their ability to go out and do activities of daily living in walking in the community, there is a more specific test that we can do for that. So we have the quick screening by the CDC. There's also the activities specific balanced confidence scale. This was put out by Powell and Myers, and it's a self-report. You can give it to the patient. It's a pen and pencil test, and it goes, how confident are you doing these 16 tasks? So if they say 0% confident, or they can say anywhere between 0 and 100%, 100% would be completely confident. They fill out the 16 items, and then you take the total score and the highest score could be 1600, and you divide it by 16 and you get a percent. If they skip an item, you just divide it by the number of items they answered. So this would be an example of the ABC scale. It gives you a little bit more information than the CDC quick scale. So if you wanted to know more about confidence, and I've used this quite a bit when I go out and do fall prevention, just to see how people feel about how confident they are. So I'll let you guys kind of read through. Pretty easy, pretty standardized confidence scale that you can use. If you decide to use this on your client, if they score less than 67%, it would indicate a greater fall risk. And it accurately has been shown in literature to classify people who fall about 84% of the time. So people have found this to be a very useful tool. If somebody scores more than 80%, they're usually at a very high level of functioning, 50 to 80% moderate. And if they are less than 50%, they're usually at a low level of physical functioning. So our cutoff score for people that have a fall risk would be those that score less than 67%. So don't worry if people don't score 100%, you usually want to see them at about 80% or higher. So Mrs. Brown's, when we did her screening, when we asked her the 3 questions that we talked about, have you fallen in the past? She answered yes to one of the 3. When we did the steady fall checklist, she got a score of 5, like we said. And when we did the activities of balance confidence, she scored a 70. So she's right, 67 would be a greater fall risk. She's just a little bit above that. Her lower scores were when she had to walk where there was more people and when her balance was challenged. So now we kind of did a subjective. We talked to her. We had her do some self-assessments. What would you include in your physical examination during the wellness visit? What are some things that you would look at? You know, generally we would take a look at observed gait. Yeah. We could type of footwear. I would check out those sandals that she tripped in. Neuropathy. Yep. We're going to screen for that. That's very important. We do the tug. Yeah. We could do looking at vital signs because she's already told us that she has a history of orthostatic hypertension, shortness of breath. Yes. Check her skin. We might do the Tenetti. All good. So wellness screen, we're probably going to look at our cardiopulmonary. We're going to look at integumentary. We're going to look at musculoskeletal. We're going to look at cognitive. So we'll do a general screen that occurs. And we'll look at factors that we might assess for fall risk and balance. And we mentioned some easy tools that we could use, the tug, the Tenetti, the bird. So I'm just going to go on to show you what we found. So when we're assessing mobility, it's very important that early identification of mobility limitations is found. So a lot of these things are modifiable, falls are preventable. If people have weakness, we can do exercises to strengthen them. We can impact balance. So we talked about the fall history. We talked about identifying medications that might increase her fall risk or decrease her mobility. CDC would also talk about assessing her vitamin intake. We talked about environmental assessment. You guys came up with that. We looked at how she's using her bifocals. A lot of times when people get older, they tend not to visit the eye doctor as frequently. Are the glasses adequate? Are there things we can do to adapt how she uses bifocals when she's walking? You guys addressed assessing footwear, maybe assessing posture, maybe looking at what is her blood pressure lying down versus sitting versus standing. Is this still a factor? So the CDC, what study program would have you take blood pressure in 3 different positions to address possibility of orthostatic hypotension occurring. What we're going to focus on today is looking at that gait strength and balance mobility test. So I linked you up to the study program, and they have these readily available for you to use as screening. So when we did Mrs. Brown's physical exam, we did do testing for orthostatic hypotension. We took her vitals, supine, sitting, standing. We did her heart rate was 105, got a little bit more when she's standing. And we figured out her BMI was at 23. With her posture, we found that she had mild kyphosis, a forward head. She's about 5'5". She said she used to be 5'6". She said she shrunk. We checked her visual acuity with her glasses on. We looked at her cardiovascular. She had a regular rhythm. Respiratory was clear. GI, she doesn't complain of any problems. We measured her strength, and we found that she had some weakness with her hip abductors and her hip flexors, and a little bit with her dorsiflexors. So we'll keep an eye on as we go along. We did the mini cog to test her cognition. So one of the M's is mentation, and she scored a 2 out of 3 out of the mini cog. She had a little trouble figuring out what was 10 minutes after 11. We looked at her tone, sensation, proprioception, deep tendon reflexes, and they were all normal. We had her take a screening for depression. She scored 0 out of 6 for that. So we looked at Mrs. Brown's medication, and here are the medications she took. Do you guys have any concerns with any of the medication? So for her tachycardia and previous stroke, she was on warfarin. She's on some medications for depression. She's on some thyroid medication, taking some medication for her arthritis. Any concerns on those? Risk for bleed if falling, yeah. Some of these side effects will be dizziness. A lot of medications listed, some of the side effects will be dizziness that can impair balance. So these are things we want to kind of screen and be aware of. You don't have to be a pharmacologist, but when you get the medication list, maybe look up what may be the factors. When we look at mobility and fall risk, you guys identified that you might do the timed up and go. Another easy test to do for lower extremity strength and balance is the 30-second chair stand test. You just have the person cross their arms and they stand up as many times as they can in 30 seconds. And there's age norms for that. The other one the STEADY program recommends is the 4-stage balance test. This is just doing a Romberg testing. You stand with your feet together, then make it more challenging, standing with one foot slightly ahead of the other, standing tandem, and then trying a single leg stance and measuring if they're able to do that for 10 seconds. And one of you did identify figuring out gait speed. So the 10-meter walk test is an easy way to look at gait speed. So these would be mobility or fall risk, quick screening assessments. If a person performs poorly on them, we would go on, refer them to PT eval or refer them to OT for further testing to be done. So this just describes the timed up and go. It says to assess mobility, both gait and balance. You just set up a 10-foot walk. You have a person sit in a chair. They can use armrests if they want to get up and down. You say go, they turn, stand up, they walk to a line, they turn around, walk back and sit down, and you time it. And so we have timing norms that they should do, and we have what would be a risk factor. So if they cannot do this test in 12 seconds or less, they have a higher risk of possibly falling. As you're watching them walk, you're also looking for any loss of balance. If they're shuffling, are they having trouble with the turning? So this has been a good test to, it's been found to be more useful to rule in than to rule out falls. And so on the study website, you can go and they have the test, the instructions, what to look for, and how to set it up for you. And then there's age norms out there. As you get older, you get to have a little bit more time to be able to do it, but 12 seconds is still the factor. The other one is the 30-second sit to stand. Like I said, you just have them stand in or sit in a standard chair, have them stand up without using their arms. Their arms are crossed on their chest. And again, there's standardized norms for this. If a person scores below the age norms for standing up, they're considered at a higher risk of falls. If they cannot stand up without using their arms, you actually score a 0. I have modified this test and still count how many times they can go from a sit to stand using their arms to help, but for the standardized test, they would score a 0. So again, the CDC has this study, has the chair stand test outlined for you with the age norms, free for you to download and use as a screen tool. So very easy to use. There's also out there the 5 times sit to stand, same thing. The person sits to stands with their arms crossed, but this time you just do 5 sit to stands and time how long it takes them. So if somebody doesn't have endurance to do it for 30 seconds, sometimes this is a little quicker. The lower the time, the better the score. And again, there's age norms. If they take greater to or equal to 12 seconds, that's a fall risk. So same test, just one is you count the number of times they stand, the other you time the number or time how long it takes them to do just 5 times. And this is showing the 4-stage balance test. And it's you start with feet together, then go to stand-up tandem, go to tandem, go to single tandem. You're seeing if they can hold it for 10 seconds. If they're unable to hold with feet together, we don't go on to semi-tandem. It's a progressive. Our end goal is, can they stand on 1 foot at a time for 10 seconds? Very quick way of doing assessment there. And again, this is outlined for you in the CDC study program. So if they can't get to 10 seconds, then they would be at an increased risk of falling. 10 seconds is usually for the tandem stance. And our last one would be gait speed, has been known to be the 6th vital sign. The 10-meter walk test, you just do 10 meters. You have them walk and you time the middle 6 meters. So you give them 2 minutes to get up to their walking speed, or 2 meters to get up to their walking speeds, and 2 meters at the end so they don't stop right at the last line. So you usually set up 4 lines. And so they start walking here. You time when it gets to the 2-meter line, you stop timing when you get to the 8-meter line, and you have them walk through. So they're having this free walking speed between the middle 6 meters. With this, if a person, we're usually looking that they walk 1 meter per second. And if they walk less than that, they're at a higher risk. So cutoff score for healthy older individuals, if they walk less than 0.7 meters per second or meters per second, is a higher risk of having a fall or hospitalization or higher mortality. So very easy test to do. If you don't have that 10 meters, there is a 3-meter walk test. It only takes 10 feet if the space is limited. And again, we're seeing gait speed being a measure that more and more people are doing during their wellness visits and with their examinations. So again, we have age norms. Men and women are a little different. Men are taller, so they usually walk at a slightly greater walking speed. So here's our case study. We have Mrs. Brown. Her TUG score was 12.5. Her 30-second sit chair stand test, she was able to do 7 stands, or if we did the 5 times sit to stand, that took her 14 seconds. When we did her 4-stage balance test, her single limb stance was 3 seconds, standing on one leg. Her tandem stance, she could only stand for 7 seconds, but she did pretty good with both feet closer together. When we did the 10-meter walk test, she had 0.9 meters per second without an assisted device. What does that tell you about fall risk with her scores? So was the TUG in our fall risk category? Yeah. She should be able to walk faster than that 12.5 seconds. Her 30-second chair stand test was 7. She should be able to do 10 or more with that, with her age category. She should have been able to stand tandem stance for at least 10 seconds. And we would have liked to get 1 meter per second. She didn't get the 0.7 that would put her at a greater risk, but she still fell below that. So 3 of the 4, she exhibited fall risk. So we have concerns with Mrs. Brown. Her concern that she has fallen previously, concerns with her past medical history, and now concerns with the screening that we did. Okay, so evidence, there was a study that was done, a systematic review of people over 65, and they found that not one test is the best to predict falls, but taking history questions like we did, taking a self-report like the ABC scale, and looking at the TUG and the 5 times sit to stand along with the balance, Berg balance scale were the most evidence supported measures to determine risk of falling. So that's kind of why I identified those for you. So if we talk about doing the screening, our next part would be how do we intervene? So what would be your recommendations for Mrs. Brown to help her to improve her mobility and to prevent future falls with the information that you gathered? So what might be things that you do once you found out this information? Would you just send her home and have her watch the Olympics on TV? Or what would you recommend? Would you recommend her to go to outpatient physical therapy or maybe a community PT eval, Lori says, for balance and strengthening? We identified that she had weakness of her hip flexors, abductors, and dorsiflexors. These are all muscles that are needed for good balance and for good gait. So yes, that would be a good one. Anything else? Senior Center, Tai Chi has a lot of evidence-based practice. Tai Chi is a balance exercise that can be used. Senior Center has bone builders here in town, which would be a good strengthening. Have her go to OT and do a home eval. The CDC website has a home eval that you can do also. See about support systems. Yeah, very good. If she hasn't had her vision checked or her bifocals checked, maybe refer back to the eye doctor. So there's looking at a review of the medication. If she says, ever since I started my new medication, I've been dizzy, maybe you refer back to the doctor or the pharmacist. So things that we can do to intervene. I borrowed some of information off of the STEADY program, but we want to make sure we create an individual mobility plan for her in her environment. She's out walking outside. We want to make sure how to make that safe. We may give her a simple technique of, when you're walking, I want you to think of heel-toe walking. I want you to strike your heel first. Then you can't catch your toe. I want you to scan the environment in front of you when you're walking. Look 6 feet in front of you and identify any trip hazards. We talked about medication, looking at strategies for her urinary urgency. There is women's health that can treat urinary incontinence and urgency. So that could be a possible referral. The STEADY program recommends that people get adequate amount of vitamin D, and evidence has shown that that is a fall risk reduction, people that have adequate vitamin D. Give them education. So educate that fall prevention, and emphasize that falls simply aren't just accidents, that there are preventable. So the CDC has fall prevention brochures. What can you do to prevent falls? Give them more information, the better for your clients. We might do home safety like you guys recommended. We might refer for exercise. If you don't feel like they need to go to a physical therapist, to recommend that they get to a community exercise program 2 to 3 times a week. Do more than just walking. Walking helps improve walking. Walking won't increase those the strength issues. She should have exercise. And somebody already mentioned looking at shoes, looking at eyes, and then set goals that for what matters for that individual. What does she want to do? She wants to go out walking outside. Make sure we're addressing that. If she wants to go play tennis, we should be addressing how we could improve that. If she wants to be able to lift and carry her grandchildren, addressing that. So I just wanted to point out the STEADY program has a My Mobility plan you can use to have the patient go to. It looks at myself, how to stay independent in their home, and how to stay independent in the community. Looking at things we can do, we identified that we could do reachers in the bathroom. We could put things to help sit to stand if that's an issue. If a person has trouble with stairs, you could do a ramp. We could do assisted devices. This is moving the laundry room upstairs if stairs were a problem. Mrs. Brown was doing okay with that. Making sure that there's a railing to use, and making sure the person's able to get out and about, do what they want. Just wanted to kind of finish with showing you that if you go onto the CDC STEADY site, it talks about what to do, yes or no. They didn't answer the 3 questions. They were all yes. Then what we go there, if they answer no, we go to different ways. So who needs to be screened, who doesn't? Once you're screened, what's some intervention, and also important for the follow-up. So these are just some of the available things on the STEADY site that you can download. So I'd highly recommend to go and look there with it. So our final question is, what are the benefits for encouraging mobility and educating fall preventions for Mrs. Brown? So why would you, once you do your screening, why would you take time to address this? What would be the benefits? Help keep her independent and at home longer. Yeah, independence, prevention of falls and fractures. Lots of evidence out there is when a person falls, things are going to decrease their level of independence and mobility. Socialization, perfect. Very good. So as we go farther forward, remember when we talked about that awful cycle of falls and immobility and deconditioning? Well, our intervention can be building confidence by keeping the person mobile and physically active, by increasing strength and flexibility, which will all decrease the falls. Less falls, more confidence, more mobility, more strength, decreased falls. So we can take this multifactorial fall screening and intervention, we can use it to reduce falls with our client and with Mrs. Brown. So here are the benefits of encouraging and promoting. The point is we got to keep people as mobile as possible as long as we can, but do it safely. So hopefully today you learned about some quick ways to screen, the references that you can access from the CDC. The study is a great way. It has so many things available to you, and Berg scale replace all the screening tests used. A screening test is something that you want to be very short and brief. So like I said, the Berg is going to take you about 15 to 20 minutes. I would do the quick screens. If they have trouble with them, I would then go on and do the Berg. If they pass them with flying colors, I won't worry about during the